This is a cataract in a Down syndrome child, and we're going to show the technique published by Dr. Brian DeBroff in 2008 of double optic capture with the haptics in the sulcus and a purposeful PCC done, as we always do, but rather than put the haptics in the bag, put the haptics in the sulcus and push it through the anterior and posterior capsular rhexis openings. So here we're doing the anterior capsular rhexis, which is routine, and we just have to be mindful to get the opening small enough but not too small. And it's always a little tricky with pediatric eyes where the capsule is so elastic to not radialize but also not make it too small. And we'll see when we capture on this one that we wished it had been a little bit bigger even than this, but I have yet to rupture a capsule even with a very tight optic capture. So we're hoping to get an opening about 4.5 millimeters for optic capture, whether it's in bag haptics or in the sulcus haptics. We're not showing the cataract removal, but after cataract removal and cortex removal, we're filling the bag with a cohesive viscoelastic OVD. And now I make this cystotome just bending the tip of a 27 gauge disposable hypodermic needle and snag the capsule, then add more cohesive OVD to push the vitreous back. And we're just applying it slowly and not so much that you break the vitreous face, but just filling the space between capsule and vitreous to protect the vitreous as the PCCC is formed. And one can stop and add more OVD during the CCC. So for this technique, we want the posterior capsule opening to be as large or just about as large as the anterior CCC. The posterior capsule is even more elastic, but with proper cohesive OVD stabilizing the chamber with some over and some under the posterior capsule, one can fashion it very well to the desired diameter. Posterior capsule acts so differently. It's so thin. So now we have an opening in the anterior and posterior capsule. We're going to add a little more cohesive OVD and put some right between the capsule and the iris for placement of the haptics in the sulcus. The 3-piece IOL is placed. One has to really twist these cartridges to get the initial haptic over the capsule. Now that it's over the capsule and secure, then we twist back to get the optic opening appropriately. Sometimes a second instrument to secure the haptic before taking the plunger out helps to keep the IOL stable. I use a Kalman McPherson forceps grasped at the appropriate place on the haptic, not too close to the tip, to get the haptic into the sulcus. And one has to be careful that it doesn't just flip out again. Saw how I re-grasped at the tip to make sure that it is going under the iris. With the OVD syringe, I'm moving it around and looking at my capsule opening. It may be stretched because of the haptic, but what I like to do is get the optic-haptic junctions on the longest axis of the CCC, if there is some ovalization of the CCC. That's why I'm moving this lens around, because it looked like the CCC was a little wider in the meridian that the haptic-optic junctions are in now. And then we just push one edge of the optic posteriorly to get it under both anterior and posterior capsule leaflets. And when it's double optic capture, we have to be quite certain that we are under both, because it can be deceiving with the capsule under looking like it's over just because of the transparency. And then we'll have to pull the optic this way and push posteriorly on the opposite side. Notice I'm just making sure that the capture is as close to the optic-haptic junction as possible before attempting to tuck the other side. I like this tight optic capture to be more secure, that when the OVD is removed, that it's not going to lose the capture as the chamber collapses a bit. Starting the capture near the haptic-optic junction can make it easier when it is tight like this. Then one always has to physically maneuver the capsule edges to be sure that it is on top of the optic, because of the way that it can look like there's capture even though it's posterior. But we could feel both, and we're sure we have double optic capture in this pediatric eye. Thank you.